Hello, this is Susan Knowles from Cochise College Nursing, and welcome to this podcast where I'll be discussing altered moods of pregnancy, specifically contrasting postpartum blues with postpartum depression and postpartum psychosis, and briefly mentioning some of the other mood disorders which can occur in postpartum, such as bipolar disorders, obsessive compulsive disorders, and PTSD or post-traumatic stress disorder. Mild depression or baby blues is a frequent concern for new mothers, and this is a mild transient condition that can affect up to about 80% of new mothers. The condition begins in the first week after delivery, and it usually lasts for a few days up to 2 weeks, but generally not past 2 weeks. And the signs and symptoms that women often describe are the inability to sleep, fatigue, tearfulness, mood instability, and anxiety. The symptoms are usually unrelated to any kind of an event, and it's usually not serious in that it doesn't affect her ability to take care of herself or the infant. We think it can be associated with hormonal fluctuations, but it really hasn't been found to be conclusive. The studies have been inconclusive. Postpartum blues must be distinguished from postpartum depression as well as from postpartum psychosis. The conditions of postpartum depression, or PPD, is a disabling condition, and it requires therapeutic management for full recovery, and so does postpartum psychosis. Postpartum depression is the most common complication of childbirth over any other complication, and yet I have to admit that I'm guilty as well of not really fully screening my patients prenatally or postpartumly for this condition, although I have had a few patients that have come forward and described some of the same symptoms that are described in your textbook. Postpartum depression usually develops within the first 3 months, but it can develop anytime within the first year after delivery. It is differentiated between the blues by the intensity as well as the persistence of the symptoms. Women oftentimes will have apathy or a lack of interest or energy. They lack an appetite and they're sleepless. Now, those are very similar to postpartum blues, except these are things that just keep going on. It doesn't get any better. She may say that she's sad, she's lonely, she is anxious, she's complaining of confusion, she can't think straight, she's crying, she can't take care of herself or her infant. And some of the risk factors that have been found are that women who have already had a problem with depression before pregnancy as well as during pregnancy, they have a family history of depression, it's their first pregnancy, they're young, they're single, they may have had medical problems during the pregnancy, and they lack social support. There are screening tools that are available to help with the diagnosis. Subjectively, she's complaining of being apathetic, as I mentioned, as well as crying and confused. Nurses should teach the woman and the family to call the health care provider if depression becomes severe or if it lasts longer than 2 weeks, or if she is unable to cope with her daily life. Postpartum depression is best treated with a combination of psychotherapy, social support, and medications. Specifically, antidepressants are the most often prescribed. Many times women who have been on antidepressants before they became pregnant, or maybe early in their pregnancies, have decided to discontinue the medication in pregnancy, and they are more likely to relapse either later in pregnancy or postpartum. And I can tell you that my own personal advice to women that were on antidepressants that stopped them is that I taught her as well as her partner to watch for those signs of depression during pregnancy, and at the first possible sign of those, that she or the partner specifically was to come forward so we could restart her on her medication. Realize that postpartum psychosis is rare. However, it is considered a psychiatric emergency, and those signs and symptoms are confusion, agitation, sleeplessness, but also hallucinations and delusions. The treatment for that is hospitalization, psychotherapy, and medications. A combination of antipsychotic medications with antidepressants are usually used. Now, those conditions of bipolar may be that a woman had bipolar prior to becoming pregnant, and she will also need to be on medication. Some women become obsessive compulsive after the delivery, and some others have problems with post-traumatic stress disorder that develop after the pregnancy, and all of these conditions need to be treated and not ignored. So if you find that someone is complaining of these types of symptoms, then we as nurses need to encourage the woman to be seen by a healthcare provider and get treated. Thank you. This is, on this slide, is an example of a screening device that can be used for the signs and symptoms of depression. And what's listed here on the slide, if you're not looking at the slide but listening to the MP3, the postpartum depression checklist is saying, I'm not interested in activities that I usually enjoy. I feel hopeless about the future. I can't make decisions. I feel sluggish or restless. I feel guilty or blame myself when anything goes wrong. I'm gaining or losing weight. I'm sleeping too much or I can't sleep at all. I feel unhappy. I feel irritable or anxious for no reason. I think about dying or killing myself. And if she should answer 5 or more of these as in the positive, then she needs to seek help. Attached to this podcast is a video where fathers talk about postpartum depression and how it affects their family and how it affects them. And I encourage you strongly to watch this brief YouTube video where fathers are discussing their experiences, as well as the other attached videos to this podcast. Thank you very much for joining me. This is Susan Knowles from Cochise College.